Good afternoon, everyone. I see people are still coming into the room, but I think we'll go ahead because everybody's time is precious. So good afternoon again, everyone. Welcome to our webinar, See What You Treat. My name is Ruth Wilcock, and I'm the Chief Executive Officer of the Ontario Brain Injury Association. Before we begin today, I would like to give a land acknowledgement, and the land acknowledgement will be from where the Ontario Brain Injury Association is located. We acknowledge the land in which we gather is the traditional territory of the Haudenosaunee and the Anishinaabe peoples, many of who continue to live and work here today. The territory is covered by the Upper Canadian Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. And been to many different land acknowledgements, and I think that it's important that we try to personalize it. And as I reflect on this land acknowledgement, I want to share with you that I grew up in Saskatchewan and lived only an hour away from the last residential school, which was in Punishai, Saskatchewan, and it closed in 1996. And growing up, I did not even know that such a place it existed. And it's with sorrow that I think of the children that were so close to me and what they endured, and yet I knew nothing about it. And so I reflect on that today and invite all of us to reflect and remember all the children, also the Indigenous women who have gone missing. So again, I want to thank you for attending the webinar today. Just a couple of housekeeping things. If you can type your questions into the Q&A during the presentations, we will address the questions after each presentation. And so I'm excited and we're ready to go. And I want to say it's with deep gratitude for the support of Synoptical Medical Assessments for hosting this webinar with Obaya. And now it is my sheer pleasure to introduce to you Mina Bichet, who is a great supporter and friend of Obaya and is always trying to improve the lives of those who are living with brain injury. So Mina, I turn it over to you.
Thank you, Ruth, and thanks for the acknowledgement. Hello, and thank you everyone for joining us today. Concussion is a brain injury. It does not only affect a person, but it affects an entire family. Clinicians sometimes overlook the concussion diagnoses for a number of different reasons. This leaves patients and their families confused and alone. Why am I having these symptoms? Why am I so irritable? Why do I not want to leave my room? Being able to actually see the extent of such injury does not only provide guidance for treatment to improve clinical outcome, but it would also provide closure for patients and their families. They get an answer to why, and that's an important step for the healing journey. With that being said, I would like to introduce Dr. Cohen. Dr. Cohen is a nuclear medicine specialist. He's also the section head of nuclear medicine department of Doctors BC. He's also a head of department at Lionsgate Hospital, and he's the lead author of the Canadian Nuclear Medicine Association guidelines for brain perfusion SPECT. Welcome, Dr. Cohen.
Thank you, Mina. I'm going to try and share my screen, which I hope you can see. Is everybody able to see my screen and hear me?
Yes,
Yes, we can.
So I'm going to be talking about brain perfusion SPECT, which is for us in nuclear medicine, something that we do every day, not for brain, but really for almost every other organ. We do a fair number of brain perfusion SPECTs at Lionsgate Hospital. And the modality is available at pretty well every major hospital in Canada, but it's not commonly performed except probably for very specialized tests, which I'll illustrate. And it's also basically used for dementia as probably the main indication. It hasn't really found a lot of use for head injury, but I think it's actually one of the most important potential uses for the technology, which I'll try and just illustrate. So let's start off with what is nuclear medicine. So what we do is we inject a radiopharmaceutical into the patient, and then it's taken up by the patient's area or organ of interest. In this case, it's showing that the heart is the area that's detected. So we inject the patient with a radioactive drug. The drug is labeled with a SPECT or gamma single photon agent or radionuclide. It localizes in the patient according to the metabolic properties of that drug. So we can target the drug, which is labeled with a radioactive emitter, to target the brain, to target the heart, to target the liver, to target infections, to target different tumors. Only trace quantities of the drug are sufficient. What that means is that basically we can only use a very minute amount. It usually doesn't cause any sort of interaction with the body. It's considered by Health Canada to be a drug, but in fact it doesn't behave like a drug because by definition it's only a tracer and it doesn't interfere with the host. And the radiation dose to the patient is usually quite small. Now, we have two ways of forming an image. One is called planar imaging, and that's like the standard chest x-ray. So here on the left, there's an x-ray tube and it's shining a beam through the patient, and there's a radiation detector, either film in the old days or now radiation panels. In contrast, for planar nuclear medicine, what we do is we have detectors, and the patient is basically made radioactive, and the emissions, gamma rays or x-rays, are coming out of the patient and hitting the detector. For a brain scan, and we actually have several types of brain scans in nuclear medicine, but for a brain perfusion scan, we inject a radioactive material that targets the blood flow, and it sticks to the cerebral cortex in the brain and to some of the major nuclei in the brain as well. So this is just showing a time-lapse picture. It shows how quickly the agent diffuses into the brain. It's what we call lipophilic or fat soluble, and it crosses the blood-brain barrier. Most drugs have a hard time getting into the brain unless they're fat soluble. It's a protective mechanism that the brain has, and it will then stick almost immediately to the cerebral cortex. So if you look down here, this is the patient's head, and inside the head, this is the soft tissue, the scalp. You can see the material in the brain. So these are planar pictures of the radioactive material. So what is SPECT? Well, it's single photon emission computed tomography. It's the same as CT. So CT was an improvement over planar X-rays, but a computer does the reconstructions on the gamma rays detected after the radioactive injection, with the X-rays coming out of the patient and not transmitted through. So in CT or X-ray CT, the X-ray tube, instead of just shooting an X-ray through the patient, it shoots the X-ray while it's rotating around the patient. For us in nuclear medicine, we make the patient radioactive, and we detect using a ring of detectors for positron tomography, the material, or we can rotate, like the X-ray does, our detector around the patient. And then we can basically form a much more accurate image of the distribution of radioactivity in the patient. And we use single photons as opposed to PET tracers, which are dual photons. By having two gamma rays, it allows even a more accurate distribution of the radioactive decay in the patient. These ring detectors are now starting to be applied to SPECT as well, but they've just been available in the last year. So SPECT has basically mirrored the evolution of the video camera. So if those of you who are old enough like me to remember the old days when the videographer in a TV studio was actually sitting on a TV camera, we've now evolved so that the cameras are now in our phones. And really, the SPECT is the same. It's evolved from a single head to having two heads for detecting, to having a CT also included with the detection. And the most recent thing is now a ring detector with the CT attached. And the detector material is solid state. So it's like the cameras, the smart phones that are in your cameras, they're solid state detectors as well. So 85% of nuclear medicine studies use SPECT. So it's not just the brain. We do it routinely in many types of studies. Probably the most common are heart and bone. And the reason we do them is because CT and MRI are either non-diagnostic or they aren't sensitive enough, or they just have other properties that are not as good as using the radioactive tracer. So on the left, a cardiac SPECT is basically one where we look at the perfusion, not of the brain, but of the heart in 3D, and we can see whether there's any sort of abnormality in the perfusion of the heart from coronary artery disease. In a bone SPECT, we are looking, in this case, for a fracture when the X-ray is normal. So even though the X-ray of the scaphoid bone, which is commonly fractured bone and fall on the wrist, is normal in this patient, the SPECT shows that there's an area of high accumulation of the radio tracer. It's darker, and so that's an abnormality. This is a tumor SPECT on a type of tracer looking for a neuroendocrine tumor. The CT is normal, but the SPECT is highly abnormal. For some reason, this is not something that's really clearly known by a lot of people in medicine. Many physicians really aren't aware of the power of our modality. So, and that's gone on to a recent decision by a court that brain SPECT cannot diagnose a mild traumatic brain injury, but neither can CT or MR. So if we look at which patient below had a head injury versus a stroke, there is no way that any radiologist looking at these two images would know which is which. The only way they would know is that one had a history of a head injury and the other had a history of spontaneous abnormality coming out of the blue, which is a stroke. But the images are really very similar. And even when a radiologist is asked, is this a stroke or is this a head injury, they're going to say it's consistent with, not diagnostic of, because no imaging test can simply diagnose an abnormality without a history, a physical examination, and laboratory tests. If it were possible, we wouldn't need family doctors, we wouldn't need internal medicine specialists. All the diagnostic specialties would simply be replaced by imaging, and it's clearly not the case. So this is a traumatic brain injury here on the left, and these are the CT and MRIs in a patient that's had a stroke. And again, the report would simply say consistent with a stroke, not diagnostic of. So by the nature of a traumatic brain injury, we can't have a randomized study of neuroimaging applied to patients with it. So how does one recruit a sample of subjects with a normal baseline SPECT and then subject them randomly to a head injury, followed by a repeat SPECT scan? So as a result, there can never be true class 1 evidence, which is the hallmark of most drug studies, well-designed, randomized, controlled clinical trial. It's simply impossible to do in a imaging study, especially a nuclear study where we are injecting a radioactive material and there's no way you can inject a placebo. So the prognostic effectiveness of SPECT can never be a true class 1. But the same limitation applies to studies of functional MRI, CT, and anatomical MRI, magnetic encephalograms, or diffusion tensor imaging. None of these are diagnostic, and yet they're used routinely. SPECT isn't. One of the frustrations for those of us that have been trying to advance the use of single photon emission tomography is it's often suggested that there isn't much scientific evidence for it. In fact, there are thousands of scientific articles looking at the use of brain perfusion SPECT. And I would say it's generally very well accepted in certain disease conditions in this list of diseases or abnormalities where it's been brought into use. It is not accepted in certain psychiatric conditions and in head injury as a routine investigator. Why is beyond me as a nuclear medicine specialist, but that has been the case by some of the guideline agencies and some of the medical imaging specialty associations. The reason that SPECT is powerful, though, is it's not got the same resolution as MRI or CT, so it's blurry, but it has 1 million times the contrast of CT and 1,000 times the contrast of MRI. So it's way more sensitive. So while it's blurrier, it is much more sensitive, and that's shown by the spatial resolution here. At SPECT, it's about a centimeter, 8 millimeters to a centimeter. That is now 3 to 5 millimeters. MRI and CT are 1 millimeters or lower, so they have much finer resolution. But their sensitivities are significantly less. So we go from millimolar in CT, which is 1,000th of a molar, to micromolars in MRI, which is 1,000,000th of a molar, to nanomolars in PET or SPECT, which is 1,000,000th of a molar. And we'll see how that shows up in different disease conditions. Now, this is what a SPECT scan looks like. There's different ways of presenting the information. Like a CT, an X-ray CT, the way the information was tended to be presented was as slices through the brain. So these are slices through a normal brain with each of the two agents that are used routinely, HMPO or ECD. These are the two carrying compounds that are targeting the radioactivity, which in the major SPECT tracer in nuclear medicine is technetium-99. That's the radioactive material, but it's carried into the brain by this lipophilic agents, ECD and HMPO. A better way of actually looking at it is to look at the shaded cortex. So this again is much more smooth than what we're seeing on the cross sections. But as we'll see, it's actually in a way more powerful and much more easily understood. The other way is to look at the hottest areas of the brain, which for the most commonly used one, HMPO, is in the posterior part of the brain called the cerebellum, which is responsible for movement, and really is the area that picks up most of the HMPO. ECD is a little bit different. It's actually picked up by the visual cortex more than even the cerebellum. Now, some of the radiology groups seem to think that SPECT isn't anatomic, but it is very anatomic. It's just different from CT or MRI. So most of the material that gets injected is taken up by the cerebral cortex, or the gray matter. And the reason for that is the flow to the gray matter is about 10 to 1 to the white matter. So we don't really see the white matter, but we see the cortex, and we see some of the nuclei of the brain. So A is the thalamus, which we can, or sorry, the caudate nucleus, which we can see quite well. B is the thalamus, which again you can see on the MR and on the SPECT scan. It's not, both of them are not any better seen for what it's worth on the CT scan. We also see the visual cortex generally much better. So it's a very, very anatomic specialty study, but it is not as fine detail because of the difference in spatial resolution, although that is going to slowly improve as our detectors get more sensitive. So how good is brain perfusion SPECT compared to MRI or CT? Well, I think it's helpful to just look at some representative reasons for doing a brain SPECT study versus a CT or MRI. And probably one of the first uses was for diagnosing death. So in a patient who's basically brain dead, initially all you'll see is brain swelling. And it's not certain whether that's just due to a head injury or whether it's been a lethal injury. Here's a normal SPECT for comparison. Again, cross-section sliced through the brain. And in this patient, there's nothing in the brain. The only perfusion that we're seeing is in the scalp. So even though the CT is showing that there is brain swelling, we can fairly confidently say that this patient is actually clinically dead. These aren't particularly rewarding studies to do. And in fact, we haven't really done many for quite a while, but all of a sudden it seems to have a recurrence at Lionsgate Hospital. So we've actually done 2 in the last 6 months. One of the major uses, and it seems to be coming back into real interest, is to use this in epilepsy. For instance, at the Montreal Neurologic Institute, which is focused mostly on positron tomography research, they still use SPECT for epilepsy. So here's a patient having an epileptic seizure with a normal MRI, but the SPECT scan shows one area of the brain because it's showing violent electrical activity at that area causing the seizure, and there's matching increase in perfusion. We can see it on the SPECT very, very easily, and we overlap the SPECT onto the MR. We can see using the MR to even further localize it for surgery. In the last day or two, there's been an article suggesting that they can actually provoke these seizures now electrically, and they think that, especially in children, this will be very useful for where the seizures are intractable and they would want to actually surgically remove the seizure focus. This is a patient who's had an acute stroke. The MR actually, in this case, does show an abnormality here, and this is the left side of the brain, but it's actually fairly modest, at least initially. This area is quite abnormal. You can see it a bit better on the CT because the area is basically become necrotic, but you can see how much easier it is to see on the SPECT. And the thing with SPECT is if there is an abnormality on the CT or the MR, unless they're very, very small abnormalities, we will see it as well on the SPECT. So SPECT will show exactly what is shown on CT or MRI, and usually with higher contrast. So in dementia, where almost always the MRs and the CTs are normal or show only minor changes, we can see significantly abnormal perfusion. Again, here's a normal, and here's patients with Alzheimer's dementia, dementia caused by multiple strokes or frontotemporal dementia. And again, this is probably at Lionsgate Hospital the main indication for doing a SPECT scan. This is again a Alzheimer's patient that was sent to me by a colleague where the MR was completely normal, and the SPECT is quite abnormal, especially on the right side of the brain. So the collective literature indicates that perfusion SPECT scans are superior to CT scans for detecting functional injury following head trauma and subacute and chronic traumatic brain injury, and potentially acute traumatic brain injury as well. Over 96% of the studies which compared SPECT to CT found SPECT identify lesions which were not evident on CT. This researcher was at Mount Sinai in Toronto when he did this study, found similar discordance, with 79% of SPECT abnormalities lacking a matching abnormality on CT, and concordant lesions were larger on the perfusion SPECT scan than on CT. This author showed that SPECT lesions were concordant in severe TBI, but SPECT was more sensitive than CT in mild traumatic brain injury. Positive baseline SPECT had high sensitivity and specificity for persistent neurologic symptoms. So if you had a positive baseline SPECT scan after a mild traumatic brain injury, and it was positive, especially if it stayed positive at around 6 to 9 months, that correlated very, very well, like 90% with the patient's symptoms. It's more sensitive for traumatic brain injury than anatomic MRI across multiple studies. This author examined 62 patients with traumatic brain injury using MRI and SPECT, which were performed within 2 weeks of injury. Using statistical parametric analysis, they found SPECT detected more lesions and more lesion volume than anatomical MRI. Pichisi found SPECT scans more sensitive than MRI as well. 79% of SPECT abnormalities lacking a concordant MRI lesion. The same is true with Alzheimer's disease, where this is now a very accepted modality. Why anyone considers that head injury would be any different than dementia, I find incredulous. This was a study where they actually looked at patients who had injuries. The standard flare injury MR didn't show any abnormality. The arrows show where there's decreased perfusion. And the axonal injury, the T2 weighted image, showed 2 deep hemorrhagic lesions and 1 that is non-hemorrhagic, exactly where the SPECT shows it. And this is from 2001. This was a 37-year-old bicyclist who had a head injury shown on the MR in the right temporal lobe. And again, it's similarly seen in the SPECT image. This is a patient who had a post-injury of a traumatic brain injury. It was taken on, SPECT was on the same day and shows diminished frontal perfusion. Here's an MRI showing a lesion here in the sylvian fissure region. And the SPECT shows how much more the whole frontal lobe is diminished in this patient. So even though there's an abnormal area on the MRI, it's much more evident on the SPECT scan. And this just shows, again, for better localization where it is on the fused MR and SPECT scans. So again, in medical legal cases, it was suggested by some of the readers that the SPECT scans were actually normal. But we don't have to read them. We actually can subject them to artificial intelligence and quantitation software, where the abnormal areas that are below 2 standard deviations are color-coded. This was almost impossible, it seems, for any of the other experts to understand, but any of these areas that are shown on the projected brains are abnormal below 2 standard deviations and markedly below 2 standard deviations in red. So this is not me reading this as an abnormal. I would say that, yes, this area is clearly abnormal visually, but this is the computer reading it and color coding it. So when a supposed expert reads it and says it's normal, when this clearly shows it isn't, you have to wonder about the expert's ability. So in conclusion, brain perfusion SPECT is an excellent tool for assessing head trauma, as well as many other brain conditions, the extent of injury usually correlates with the SPECT findings. It's more sensitive than MRI or CT, although it can miss small areas of damage as its resolution is less than CT or MRI. Like CT and MRI, the findings are not diagnostic of head injury in that there is no one pattern that can differentiate the head injury from other conditions. In fact, some of the severe head injuries look almost exactly like advanced dementia and presumably have very similar diagnostic assessments by the neurologist. However, if the SPECT scans and MRI are normal and the SPECT scan is abnormal, this would rule out a lot of confounding conditions such as stroke or vasculitis, and other confounders such as substance abuse, dementia, psychiatric abnormalities can often be excluded as they are in other conditions on MR or CT or chest x-rays or anything else based on history and physical examination. In other words, the SPECT scan can't be interpreted simply in isolation. It has to be correlated with all of the information. But however, some issues such as previous head injury or the age of the injury cannot be determined. So if patients had a previous head injury and then suffers a second one, there's no way, unless you've had a previous SPECT, that one could differentiate that. Okay, so that's my presentation. I'll stop sharing and happy to take any questions.
Thank you, Dr. Cohen. We do have a few questions that were sent in through the chat. The first one is there an age minimum and maximum for SPECT scans?
The answer is no, but children are generally preferred not to have it unless it's clearly indicated to help with the diagnosis, simply because we don't like giving children any sort of radiation if we can avoid it. Having said that, I showed a lot of patients with epilepsy where the epileptic focus is clearly seen on SPECT, and it's that type of SPECT study is used routinely in children. In fact, it's pediatric hospitals that probably do the majority of the epileptic SPECT studies.
Thank you. I think we have time for maybe one or two more questions. Here's one. Can you review or talk about the differences between PET versus SPECT scans?
PET is probably better in terms of anatomic resolution than SPECT. They have more counts, and because they're using ring detectors and more advanced software, the images are better. The standard PET tracer is a glucose analog, whereas we're using perfusion tracers, but the images actually look almost the same. Finer detail with PET. The problem with PET is it's almost impossible to obtain a PET neurologic scan in Canada. There are centers such as the initial site in Burnaby that offer it, and certain places like the Montreal Neurologic Institute do a lot of research with it, but most of the PET scanners in Canada are used for oncology, not for neurology.
Okay, Travis asked, when is the best time to do a SPECT scan from the time of the accident?
I would say as soon as possible after the accident. But generally, when the CTs and MRs are normal, there's a conclusion that everything is fine with the patient. And so normally a SPECT is not ordered until 1 or 2 years after the head injury.
Okay, we'll do one more question before we go on to Dr. Thornton's presentation. Is it possible for SPECT scan to show a brain as normal, although a TBI exists?
I think the answer has to be yes, because in medicine, as I always say, you can never say always or never. So yes, if there's an abnormality below the resolution of the SPECT scanner, which is about a centimeter, but we wouldn't see it. But that would be very unusual. PET might see it if it was below a centimeter. Their resolution's 3 to 5 millimeters. But we would see most of them.
Great, thank you, Dr. Cohen. If anyone has any further questions for Dr. Cohen, please write them in the question and answer chat box, and we might be able to get to them at the end of the webinar.